Busy almost end of the week. Good evening, everyone. This is Kristen Alex, and I'm joined by Susanna Fitzpatrick. And I see there's about 10 or 11 people on climbing. We'll give it another like 30 seconds before we kick off this fun and adventurous evening. For those of you who are on the call, I'm located in Denver, Colorado. I'll actually introduce myself. I'm a nurse practitioner. I work at University of Colorado. I'm a lead for my advanced practice division. I oversee about 5 employees. I have been involved with the Society of Vascular Nursing since 1997. And this year I'm a president, and one of my loves is engagement of our society and education. And one of the things that was very important for me to do this year is to have educational opportunities and really try to expand the breadth of our membership for those of us who want to do things like education and research and new topics, something outside of the scope of our conference. So I am very pleased to be joined tonight by the very esteemed Susanna Fitzpatrick, who is a member of our board, and she comes to us tonight with a breadth of research experience, and I will let her introduce herself as we're still letting people in.
Hi, thanks, Kristen.
Susanna.
So I'm Susanna. I'm thrilled to be here. One of the things I'm really passionate about is helping and mentoring APPs as they emerge into professional practice and writing. I think we don't get a lot of information of how to do that in nursing school and PA school and NP school. And it's something that I really spent, the past 5 years really focusing on myself and helping others. So I was really excited to have our conversation tonight with Kristen. We're going to do a little PowerPoint just to go over some key points, and then we'll do an exercise where we'll sort of dive right into it. So we will just get started. I'm going to share my screen. Oop, Mo, you have to run it.
Before you do, I just want to tag on to that, how this kind of organically happened. So we know that research is important with every aspect of vascular nursing. Nurses research all the time, nurse practitioners research all the time, PhD students, obviously leaders. There is a breadth of people who we need to publish. We need to get our ideas and our fantastic thoughts into the Journal of Vascular Nursing, or any journal really. So I'm going to be used tonight as a guinea pig because yours truly has not really published and is very scared to do research, but have a lot of brilliant ideas. And what we saw from the conference last year is we saw our wonderful practice and research committee, which Susanna is a member of, kind of take these ideas and put them into action. So this is kind of what we talked about just a couple months ago. Susanna turned to me, she's like, well, let's, turn to each other, and I'll take your idea and let's put it into action. So before we do, we're going to do a brief outline of what Susanna tells all of her students and people that are interested in research. So we are taping this. If you want to reference it later, I think it's going to be fantastic. So go ahead. Sorry, I just had to tell you that one thing, and this is why we're doing it.
All right, cool. You'll see that I work for University of Maryland. They know that I'm using their slides. They're very nice. And so I'm going, my daughter is coming in. Of course, Paige, I cannot talk to you right now. So here we go. We're going to talk about diving into the research waters. Okay, so I really want to talk about like what an abstract is, and we're going to do an exercise, but I think it's important to sort of think about when you hear people say like, let's do an abstract. It's usually anywhere from 100 to 300 words, sometimes a little bit more, but it usually has something specific. So when you're going to a conference, or you're thinking about a poster, or you're starting to write a paper, the abstract is sort of the beginning place that you will start. It's going to have a statement of the problem, the methods, results, and implications of your findings. Before you begin, hey, I have an idea, and we'll talk about that a little bit more. You really want to read the directions, understanding what they're asking you. How long does it have to be? What do they want you to answer? And then have a buddy who will help you write. So I am lucky enough, I have a great writing partner who's done a ton of writing with me. But she and I sort of bounce ideas off of each other. One person will start an abstract, then another person will look at it. But in our institution, we actually have a evidence scholarly committee where we'll help you and mentor you and provide some edits for you if you want. And if you don't have that in an organization, you should think about it because there are people writing. Give yourself plenty of time to write, but also give yourself a deadline of when you need to be done with your edits so that another person can look at it and things like that. So you really want to think about it. What am I saying? And is it relevant to the topic that the conference is trying to have people come into? So if I'm picking a conference that's like about the Journal of Vascular Nursing, but I'm really interested in writing about, cholecystitis, that's probably not going to be appropriate. If I'm really interested in writing about leadership, then how do I want to put a lens on that if I'm going to talk to an NP conference? Not every conference has a theme, but lots of them do. So I always tell people, go to their website, just kind of spend 30 minutes reading their website, see who's chairing it, what is the theme, what questions are they asking you, so that you can be ready when you start to write your abstract. There's always a deadline. These usually are not negotiable at all. So if you miss it, that's it. You can't really write, oh, I'm so sorry, I forgot to submit, things like that. So that's sort of a bummer. So you really want to give yourself a hard deadline if it's due February 1st, that you have it completed by January 1st so that you can get some edits or double check it or leave it for a few days and come back to it. And then also it's always good to know when you should hear back from them, because then, when you submit it, you're like, okay, I should hear back from them by April 1st. It's April 15th. I haven't heard. You should always get an answer, yes or no. So if you haven't gotten an answer after the deadline, I would circle back with them just double checking, or maybe something went to spam. So now you're sort of ready to think about it. I really want to submit an abstract. What does that mean? Okay, so I'm going to get a title. I'm going to try to pick a category. What type of submission is it? Am I doing a poster versus a presentation versus am I doing an interactive? And almost always they'll ask you learning objectives, like what will the audience gain from it? Here's sort of the beginning. This is from our vascular conference that's coming up. The proposal time has ended, but if you're thinking about it for next year, it's just a good example of how to walk through it. So you'll see you need a title. What kind are you picking? Are you picking a podium presentation or a poster? You'll also see often that there's characters and how many words. Thinking about your title is also important, right? People are going to read it maybe in the brochure or read it online, and they're going to go, what is this? Is this bringing me in? What kind of track are you going to go with your abstract? Oftentimes conferences are sort of tailored in different directions. So think about what direction does your fit in. Similarly here, you're going to see a summary. You're going to see there's 300 words max. And then the description, which is slightly smaller than the summary. It's what your audience will learn. With that, they're going to ask you almost always, what is your objective? What is the audience going to learn by going to your session? At the conclusion of this session, the audience will have learned, will have understood, will be able to demonstrate. Those are kind of the objectives. So this action words, you really want to use that. What is the audience going to gain after when they leave there? I think is really appropriate for them. So why do we even care about an abstract, right? So we really want to sort of show the progression of it. So I have an idea in my head. I'm going to start thinking about an abstract. That abstract hopefully will be accepted for a poster. After a poster, hopefully you will present it. And after the presentation, publish it. So with one idea, whether you're doing a QI initiative, a literature review, you're doing original research, you're on an IRB by yourself or with collaboration, you can really get a fair amount of publications and or sort of APA citations on your CV, which really shows sort of worth for the organization, worth for yourself, and helps you when you're thinking about your next professional step. So I have an idea. What do I do now? Who's sort of going to help me do that? Who are the stakeholders or who might have an interest? Am I doing QI or original research? I don't even know where to think about this because I just started my job, or I don't really understand the topic, or I've been in practice so long, I'm not sure I'm able to do this. Everybody is doing some sort of QI. You might not know that it's typically what it is, but if you're like, hey, I'm really interested in about nursing education, or I'm interested in helping the patients understand what their disease process is, or I'm interested in helping formalize the orientation process, right? All of those are sort of initiatives that you could put into a writing format, depending on how you work it. So it's always good to think about like, what kind of work do I do other than the exact patient care? There's lots of sort of invisible work that we're all doing, to quote my friend and boss, Sarah. of what we're doing outside there, and that's important work too. And there's a way to sort of formalize it and put it down on paper. So with that, we're going to go through this little exercise with Kristen that I do with other people when they're interested in thinking about writing. Let me go to a different screen. Okay, and we made a QR code just so you can think about it if this would be helpful to you when you're doing it. There's small bam on the outside. Let me make it a little bit bigger.
Oh, yes, please do.
Yeah, I'm going with my old eyes with my reader glasses.
I'm sure a lot of us out there have them. Or maybe not.
Maybe not.
All right.
So,
All right. So here we go. I've never done this before, people, and we're going to do it right now. And I'm super excited because this is something that is close to a passion project. And I'm sure that's a lot how, what Susanna just described with the invisible research we're all doing and the invisible passions that we all have. One thing that I have noticed in my clinical practice is that the vascular surgical patient is notoriously the hardest patient to discharge from the hospital. And you can give me an amen silently, but I can tell you there's a lot of case managers I've made kind of, be very upset or, keep a patient in the hospital until I knew they were safe to discharge. So what I did is my purpose, putting an idea into action, as Susanna likes to tell me, is I developed a mnemonic for the new either nurse or physician assistant or advanced practice professional, or even a resident, to know when these patients are to go. And I called it SENDEMS. It's SENDEMS. And it basically is a checklist of things that you have to go through to think that they're safe to leave the hospital. So I'm calling my idea SENDEMS, a tool for discharge preparation for the team in order to prevent readmission. How does that sound?
I think we need to go further. So, and I'm just sort of like taking notes. So here is, okay, so your purpose is that you want to, that's not exactly your purpose. So your purpose is you want to educate people, you want to update people. Is this a new concept? Say more.
Yes, it is. I would like to utilize this a validated discharge tool to enhance discharge readiness education for providers. But I don't know if this is a QI project or if this is a research project, because my goal, if we instituted this on discharging vascular surgery patients, would it decrease readmission?
Okay, so hold on. So you want to improve education to providers for safe discharges for vascular surgical patient?
Yes.
Okay. And then, okay, so you have sort of a purpose. So now we need to go to the why part. Why are you interested in this?
Why am I interested in it?
Yeah,
well,
so you're worried about, so is there an unsafe discharge problem?
I think we see in our vascular surgery group that we have a number of readmissions because of inappropriate discharges.
Okay,
and I
so
think that we also have a knowledge gap for new or not as, I guess, astute people that are new to vascular surgery, that they don't know how to safely discharge these patients.
Okay,
and I also know
whenever you, so if you have a concern, so having an idea in your head of what is happening versus what actually is happening is a different thing. So do you have any data to support it? Or are you saying you're concerned that there has been a rise, but you don't have the data for it?
So anecdotally, I can say I have a concern for my small cohort of people. Looking at research, because I know that's the next question you're going to ask me, there are, I think it's like 27% I found in my studies of patients that are discharged and readmitted could have been preventable readmissions.
Okay, so
and
typically vascular normally has a very high rate of readmission. So it's sort of good to know that as a baseline. And so when you're developing a topic to say, I have a concern, or I'm noticing that this is getting worse, you need to, I would always then first like go to the literature. So like I have has a concern. What does the literature say? Literature say of readmission of vascular patients nationwide?
Yes.
Nationwide. And what does the literature and your hospital QI say your readmission rates are and why. So they'll be able to tell you that, right? So hospitals are required to keep track of readmissions because they're all Medicare generated income, right? Of high risk readmissions within 30 days. We all sort of know that if patients are readmitted within 30 days for COPD, chest pain, shortness of breath, polypharmacy, there's like a couple, heart failure flag ones, right? They don't get reimbursed. So hospitals are required to keep track of how often patients are readmitted and what the percentage is. So it would be good to know. So first, I would say it like this. So then I go down here and I sort of make myself a to-dos. What is the hospital readmission rate for surgical patients? And they have to divide them up between surgery and medicine. There's a hospital for surgery.
And they could probably even quantify that for vascular surgery too, couldn't they?
So they can usually run a report. So report of readmissions of vascular, of your floor, of your by provider. They can run a report to that. But what you can do is you can do an assessment, right? So you can do a retrospective chart review, chart review over a period of time, 30 days, 3 months, whatever, and sort of see what it is. And then you could compare it. So then you'll have comparison to saying 2023 readmissions were this. In 2020, readmissions were this.
Now, we have some statements, some very nice statements from the chat from Renee. She says, considering making your purpose statement on patient improvement, improve health literacy among hospitalized vascular surgery patients preparing for discharge by providing discharge prep program, or reduce readmission rates among vascular surgery patients following discharge by providing a patient education profile. And I agree with you. Those are all valid points. That would probably expand the topic to a patient education program for sure. But the tool that I'm using is pretty much for providers, but that is also good information.
But I don't think we're there yet. Because I think
I don't think we are too, but it's good thoughts.
Yeah. So yes, and we can circle back on that. And sometimes when I'm making this stuff, I'll have like other things to think about. Like this is going to be my next thing, or the other data that I'm going to pull when I ask Epic to do something. Epic is our electronic medical record that we use. Okay, so we have some questions. Now we need to go to the data to see if the data supports it. Let's say the data doesn't support it, right? And you're like, gosh, I really think something wonky is happening, even though I don't have the data. So you can still go get further information. So it sounds like you are concerned that providers are having problems discharging patients. So you could give them a validated tool to just get their education about discharge. How do you review their medications? Do you ensure all patients have a follow-up with a PCP? Do you see patients within 2 weeks of discharge, right? You could give them, I'm sure it exists, a validated knowledge-based discharge tool. So like maybe we don't know this. So let's say we'll go up here. So what are you interested in? So let's say the data doesn't support my hypothesis. Okay. But you could still get more information, right? You could give validated survey to the providers about their knowledge on discharge. You could also look at who is discharging the patients, RN, APP, MDs, and see if there's a difference in their knowledge gap. Like maybe the MDs, they're discharging the patients, the interns are, maybe they just got done with medical school and they don't have a firm knowledge about medication reconciliation. Maybe it's only going to the travel nurses who just came to this floor and had been at L&D and it's not used to this, or maybe it's APPs who are not, like, you just don't know. So if your data does not show it from the medical record, see if it's there someplace else. Because usually if you have a thought and you can say like informal feedback from providers reported that there was concern about safe discharge. Informal feedback may report. And that's okay too. That can generate where your problem thought came from, is that, you know, there was this conversation piece that like, I think that there's an issue, or patient HCAP scores after in the clinic reported that they were unsatisfied with discharge from the hospital, reported that there was medication concerns. I don't know if any of your patients do, like, does somebody call them afterwards? Like we have that at our hospital, somebody will call them afterwards with some standardized questions. And so if those questions flag something, maybe you can pull those questions and see what they say. And I don't know, I mean, you have to think about like how you're going to sort of get the information. Because after all of this, if you can't really find like data to support that there is a problem, it's just your perception, you can still say, I created a standardized tool because there wasn't a standard of how to discharge. And you knew that because informal feedback reported that everybody was discharging a patient a different way, you know, going from 15 minutes to 1 hour, reviewing medications, not reviewing medications, whatever that may be. So getting some of that information. But let's say a retrospective chart review reported that there is an increase in vascular surgery readmissions over the past year by 20%. So let's say we have, okay. And so you said, okay, I'm going to create a tool. So now, so we're going to make a hypothesis that let's say there is data. So purpose is, why are you interested? And then we're going to say, data reports there is an increase in readmissions for vascular patients. And so I'm making this part up, right? But we have to go someplace. And so tell me about the tool.
The tool is basically a check off of things that have to be accomplished before the patient goes home.
Okay, who created it?
I did.
Okay, is it validated?
No, just in my own mind.
So if you create a tool, which people do, tell me why somebody else would think it's an important tool. Because it's not going to be just Susanna thinks this is an awesome tool, so we should use it, right? That's not going to.
Oh, sure. Yeah.
So you can say, right, maybe you utilize the tool. So you can say, prior to the tool, our readmission rates were this. We did a 3-month pilot trial with using the tool, and our readmissions were this. But I think there's a lot of literature to say that doing a standardized approach to discharge, doing a standardized approach to sending medications to pharmacy, a standardized discharge to patient education does exist. So you could say that. So you could say something of prior to implementation, it was noted that there was not a standardized way to discharge patients safely home. Literature reports that patients who are educated about their medications have a PCP visit scheduled within 10 days prior to following discharge.
Now that's that's been studied.
Say it again.
First, I said that what you're writing there has been studied.
Yes.
So
that's what I'm saying. So that's why you can say this. So if you're making up a tool, so hold on 1 second, post-up within 30 days of discharge. So we know the literature says that this is true. And what you're saying is at a large inner city hospital, it was noted that patients from the vascular surgical floor did not have a standard discharge education or communication or whatever, something like that, right?
Yeah.
And then so then you can, because you know that the literature says that. Utilizing the literature, a standard tool was developed to provide a different word than standard, but I don't have one right now. Just provide standard discharge guidance for all patients.
For all providers discharging patients.
For providers.
Yeah.
Okay. I would encourage utilize. I would encourage you whenever you need a tool to use a validated tool.
Okay.
Validated tool. Gosh, I cannot spell. And the reason I say that is because part of what your paper or abstract is going to be for future implications. Utilizing this validated standard tool can be useful at other large institutions to enhance safe discharges home, right?
Right.
If it's and validated just means
Mhm.
that, it's sort of a subjective term. It could mean that 3 people said it was okay. It meant that right, valid just means that it was replicated again and the same results happened. So if there's a way for you to, and it doesn't exactly have to be, for a perfect tool that you took all 10 questions. It could be you pulled 5 and you tailored 5, or you pulled 10 and you had to tailor all of them to not say ER patients, but vascular patients. But if it's been validated, then it's easier to replicate it. And then you have a more sort of stronger foot to stand on when you're asking another team or another place in the hospital to utilize it. Does that make sense?
Yes. Renee is texting furiously. Validated tools yield valid data. Valid data allows you to draw valid conclusions. Face validity, content validity, and criterion validity. All good words.
Yeah. So there's
Someone's published out there. Name Renee.
Okay. So valid and reliable are all important things when you want to like use a tool or use a piece of it. Okay. So normally if you are, so then you ask me a question like, is this research or QI? If you are not impacting the patients, but if you are not impacting the patients in terms of like any of their standard of care, it's usually not original research from a medical standpoint. That being said, anytime you touch a patient and change the way you're doing something, so in this case, you're educating providers to use a tool and then asking them to discharge it, you do need an IRB. It probably would be deemed not a human subject because you would just be reviewing charts and then giving a tool. And many DMP projects are similar in this. It's sort of like a QI initiative. You notice that there's a problem, you're going to standardize something and off you go. So I would suspect you need an IRB.
Are those hard to get?
No. And we can do another thing sometime about an IRB. And it's sort of basically saying like, here's the problem, here's what I'm thinking, here's the tool, you upload the tool, you say it's not human subjects, I'm not impacting their care, I'm not offering them any, different medications or drugs, things like that. So it's, this would be deemed not a human subject. And then it would be fine. And I don't know how fast your hospital works, but it goes, very quickly. Where we work, you get it back in like 48 hours or something. And then it's good to have, right? Because then you have an IRB to get something going. It's another piece to add to your CV, and it's another piece to add to your paper, because when you get to the paper writing concepts, one of the subheadings is ethical considerations. And this is where you go, tool was sent to IRB, or information was sent to IRB, it was deemed not human subjects, here's the number, all other ethical considerations and data protection were performed. Because all literature wants you to be able to say that, right? Because our job is to take care of our patients and to do the thing that's the most ethical. And that's one of the purposes of the IRB. Okay. We can talk about that another time or this time, or I can help you walk through that sometime. Okay, so I'm hearing that we created this tool. It would have been awesome if we can get the data to what it is before and after.
Okay.
If you created this tool, which is great, I hope that it came from someplace. I mean, I'm sure it did, right? So you looked at the literature and says to do this and says to standardize these things. And so you would sort of talk about that a little bit, about where that tool came up. And then you would write a little table about where that came from.
Came from my brain. Didn't come from any literature I looked at.
You want to try to find some literature.
Okay.
Talk about in it. And
all right, then what?
Okay. All right. So now we sort of have our purpose, is we wanted to like educate providers. Okay, cool. So now that we're thinking about it, you should always go in a step-by-step process of like, do a poster, then present it, then do
Okay.
your paper. So let's say we're going to do a poster. So this poster could be for lots of conferences: a vascular conference, an education conference, and a nurse conference, a surgical conference, right? It fits
Could
a
I
lot.
potentially put it as a poster for the SVN conference?
Uh-huh.
We're still open, right?
We are.
Well, this will hold my feet to the fire.
So you're cool. So you have a poster, which is great. And so then after you do your poster will come up and have some tables. It'll have a chart that you did. It'll talk about the data. You'll talk about the tool, and then you'll sort of be able to do that. So let's say now we're ready to write it for our paper. And we want to think about too, like, who
Okay.
is your intended audience? So when you're going to write the part, so do you want to educate providers? Do you want to have this as like in a surgical surface? Do you want to have this for APPs to champion this process? Like, who is going to be the person that you want to educate?
I think it would be best to educate people that are discharging the patient. So it could be anywhere from advanced practice to nursing to residents. Because I think the tool would be easy to use.
And I would say that like tools is a very nursing APP lens. And so that's
Okay.
usually championing that, and certainly where I work and literature I read. You're not usually reading like a surgical team decided to utilize a tool. It's usually like a multidisciplinary team, which oftentimes has nurses or case managers or APPs to sort of champion that. That's not a dig on surgical residents. I just, in the literature that I read in the institution I work, they're not usually championing that process. So you really want to go to the person who's going to read this and be like, oh man, this is such a good idea. We should do it at our institution. And who's going to do that for you? So I think, it's a great opportunity to do it either in a vascular nursing lens, do it for the vascular nursing journal, do it for an APP journal, things like that, who will sort of like champion your process, I think would be helpful.
Okay.
So like consider who will do the work when you submit.
That's a really great point.
Recommendation, because why maybe like the Journal of Vascular Surgery should read about this. I'm not sure they're going to be championing your process for it. So just think about it. And you have a good opportunity, in your institution to champion it throughout the divisions and the hospital and different units. But, I do think about that. So we sort of talk about why you're interested. What does the literature say? So let's talk about like how you're going to go to your literature search, your literature search.
Yes, please. Let's do that.
Okay. I'm going to put it on here. Okay. So what search engines do you use?
I usually use PubMed.
Okay. And you have access to it from your hospital?
Yes.
How do other people get access to it? Do you know?
I don't.
So in theory, teaching hospitals have it. If you work at a school or teach at a school, you get it. But it's not always as freely accessible. You almost always can see the abstract, but perhaps not the entire article. So just consider like, can you get all the literature that you need and review all of that, be able to review what you want. Cool, but you use PubMed. Do you put any search years on it?
No, I have not.
Okay, so you typically want to find literature within 10 years. And at the rate of publication, I cap it at usually 8 years. That way it gives it time to get edits and send. But again, so there's a little bit of leeway, but once you find your journal, look at their guidelines, and it'll say how long that they can have their your articles. It'll say all references have to be within 10 years, or you can only have 10 references, or things like that. So think about what they're doing, and there's always a information for authors.
Okay.
Great. Other search engines that people use. People do use Google Scholar.
I have not yet, but I've heard of it.
Google Scholar is great. I mean, use scholar.google.com. And it is, open to everybody. It's the reason I like it. I'm not able to always find all of my articles, but it is a good starting point. And if you hit cite, it'll pop up your references in APA format or AMA format, however you want, and you can just copy and paste it, move it over into your reference list when you're writing your article. I think people are really afraid of APA and don't necessarily know how to format everything correctly. And so you can use Scholar, Google Scholar you can just click the cite button and it'll pop up for you for APA.
Now, I've heard there is like a online tool that some academic institutions have that you can save your articles in with the DOI as well. Do you have a favorite?
I mean, I don't use that. I pull Google Scholar and then I use Google Drive to like save articles as PDFs and things like that. I don't use it for that way, but I know people do. And so, spending some time, even just reviewing literature, I think will help you figure out what your system is to find your articles.
Yeah, I think that's really important point because, organizational strategy, because you can go down, I think what scares people about doing research is there's a lot of rabbit holes.
Oh yeah, for
You
sure.
can take a simple idea and all of a sudden you're down 5 rabbit holes and you didn't mean to be there.
Totally. So I usually tell people to like pick like 5 to like 7 articles to begin with to just have and either print them or save them as PDF and highlight them. Just pick them based on what your search engine is. So what kind of search words would you use for this?
I would say vascular surgery discharge tool.
I think you're going to get too little. So I think just like validated discharge tool, decrease readmissions, surgical patients. Oops.
I told you I was new at this.
maybe surgery discharge tool.
Okay.
I also would think about like maybe not optimal, but like people who discharge.
Yeah.
Maybe figure out who that is, because maybe you all need to set a standard of the intern of all the people that people study, the intern does the least proficient of the med rec, right? Because they haven't been a doctor 5 seconds. It's not their fault. But in 5 years, they might do an exceptional job. So you might have to say, oh, we're giving the intern 50% of our discharges. Maybe that is one of our issues that we need to reconsider. Something like that too might pop up to you in addition to you being able to write this.
Yeah. Renee also posted Mendeley population intervention outcome is another thought. I think they're talking about the toolbar. I like that. Population intervention outcome as the key words.
And I think that's mostly for writing part 2.
Okay.
And so this usually takes me like, I don't know, 25 minutes, and then people will leave and then think about these things, right? And this is sort of like word dump. You're just sort of like thinking about ideas and you see it's not in perfect order and things like that. But now I'm sort of like making progress. And so my expectation would be like, okay, do all of this, pick some articles. Now let's have our conversation again. And so now the next time we meet, we'll be sort of ready to like write our abstract. And usually that's like a problem statement, maybe problem / background. And then it'll say methods, results, discussion, implications, practice. And so now we'll be able, now that we've had this conversation, we can sort of say like, okay, it was noted at a large inner city hospital in Colorado that there was an increase.
So you're just writing your experience.
Yeah.
And the background of why this came to fruition.
In vascular surgical patients.
Yeah.
Patients. Oops, I'm not gonna do that yet. And then you'll just say like, and then your methods will be like retrospective
analysis.
Review revealed
XYZ.
Yep. A validated discharge tool was tailored for this division.
Oh my God, you make it seem so easy.
2023 for a 12-week pilot. Providers were given a 30-minute education on use of the tool, and clinical expert was available every shift to assist with discharge pool. Patients were reviewed for readmission within
This is
30
great. It makes so much more sense
Okay.
when you use this document.
Okay. Sorry about my spelling. I wish I was better.
You're fine.
Results. And then you say in 50 patients were discharged utilizing validated tool.
Does it matter for people reviewing if there's what the number is?
You mean the sample size?
Yeah.
No, your N never matters, because what if you're doing something like, as long as it's shows a value is the answer. Because like, let's say you have only 10 patients, but prior you had 5 of them would have been readmitted and this time 0 were, right? It's sort of like comparing of them. It's always better to have some valuable number in terms of like, if we looked for 12 weeks or we assessed for the year, right? If you're only looking like, oh, in a 1-week period, right? That's sort of like a nothing. You sort of want to show some time period is usually, and then, the number, you don't want it to be 0. I know that sort of sounds like I can't give you an objective number, but it would be something significant enough that it would make you go, we should do this in another unit, or another team would want to do it.
Mm-hmm.
Remained out of the hospital after 30 days.
All right, we have 15 minutes left in our talk tonight, but I just wanted to go through this exercise with somebody who knows, how to do this. So obviously, our DNP PhD candidate sitting across from me today
I'm not a
knows
candidate
how
yet.
to do this
Next year.
very well. So we've had a lot of things. For problem background section, we can add data, says Jacqueline.
Yep.
And
say the literature shows that this should be a readmission rate. At this hospital, it was noted that the readmission rate was more than 50% of the national average. Yep, you're totally right.
Nice. I love that we have so many people chiming in. This is great. We would love to open it up to anybody else. Renee also says for QI, you would want to consider equity inclusion for all eligible patients. Sorry.
Yeah.
I gotta put quiet. My dogs are barking. But at this point, would anybody like to raise a hand and ask Susanna a question? Susanna, you can see the chat, right? Or no?
I can see it. Mm-hmm. Renee.
How do you go about, thank you very much for all this information, and sorry for all my chiming in.
I love it.
QI is very near and dear to my heart. And there are principles, QI principles that we try to follow so that our scholarship is sound. How do you go about identifying the best fit in terms of a journal for your potential publication? Because I advise students, they say, I want to publish, and that's great. And the first thing I have them do is really, thinking about their ideas, of course, but then consider where you want to publish and what journal would be the best fit. So how do you recommend going about doing that, given that there are so many journals out there? What advice do you have for students?
I mean, it's a great question, right? And it's certainly, publication is very intimidating. I think if you already have your abstract and your title and you've already done that piece, and your next piece is that you're ready to do the paper part. I mean, I think literally putting your title in, put it into Google Scholar or PubMed and see what other articles that are like-minded come up. And I go to those journals for where that goes. And I look at the impact factor. I read it. Do I make sure it's peer reviewed? I see are articles there of interest to me? Are there other like-minded people like me? If I go to a space that everybody that has published there is a social work, because I'm talking about, but for whatever reason it came up, I'm not sure I'm the best author for it, but I don't discount it because maybe I'm talking about something that's really important to all of us in our multidisciplinary team. You can also query the author, the editor. All of the editors are listed there and say, I'm really interested in here. Here's my abstract. What do you think? And I would say every time I've done that, I've gotten a very thoughtful response from the editor, usually within a day or two. And if it wasn't the right fit, they've always given me recommendations for other things. So, that's sort of what I do. Impact factor is listed on their websites, and that just means is how often are people looking at it. You could Google it for any journal that you read that's peer reviewed. They all have to be listed with their impact factor. And then if you're not sure what impact factor is and what that means of how often it's being looked at, you can also Google like what the definition of impact factor is. Is it getting better or worse? And I think that's important because exactly to Dr. Franquist's point is that there's so many journals out there and it can be very saturating. So just to make sure you're finding something that's thoughtful.
Yeah, I think it's a really good point what you brought up about writing for and being that journal being interested in what you are writing towards. One of the things that I'd like to plug with our Journal of Vascular Nursing is all journals, and correct me if I'm wrong, have an editorial board. So you will submit to this board and they will review and then give you feedback on how your article looks and how it's presented and just like any of the tweaking. One thing that I thought was really interesting is because there are so many journals, we get a lot of foreign submissions at the Journal of Vascular Nursing, and sometimes the edits are just formal grammar issues. But we have a board, I think it's 12 people now on the editorial board that go back and forth and really try to give you every opportunity to have the best submission. So we are small, but I think we are very mighty, and I think our journal has won a couple of impact awards for things that are pulled from it. So I want to say that we also have a robust practice and research team. I mean, Susanna has been so gracious with her experience and her, helping and coaching people. There's been several members she's coached an article out of, and it was the first time people have published. So I'm not, we're trying to encourage more people to do this, obviously. And, take your foot and put it in the water. I just had my annual review and I love to teach. And I just said to myself, that's one thing I'm not strong in, and that's okay. But the person doing my review said, I noticed you haven't published. So it is something kind of near and dear that I am so glad I have this web of people I can ask when I finally, get these ideas and how to bring them to fruition. So this is, just a great thing that you've done with me tonight. And I really appreciate it. It makes so much sense. And, I'm kind of like excited now to get started on, this and like bring it back to you and show you what I've done. Anyone else have any thoughts or questions?
Yeah, I mean, it's not as daunting as it has to be. I mean, it really isn't.
Right.
I know it feels like it, but it's such an important thing that we do. And just like you said about editorial board, I mean, I'm on a few editorial boards because I really like writing and editing and things like that. And so, there might be people in your institution who are doing those things, and you can ask them for some mentorship on this process too.
And we encourage any clinical research, any QI project. You don't have to be a doctor prepared nurse. You can be a bedside nurse who notices there's something going on that you don't like and a way that change it. We can dive into, quality improvement as well. So, it's something we really want to encourage from, all of our members and all of our nurses, because we're the ones that have these big ideas that, you can take to something and it can blossom into something huge. It'd be very impactful, even nationwide, for these patients. So anyway, what's the next step? Do I write this up and check in with you, develop my tool and use it, get maybe a nurse researcher to help me with this?
I mean, I would say give yourself a deadline for one thing and be, kind to yourself. If you're like, I'm super jammed up for the next month, I really cannot dedicate time, that's okay. But I would, I say to all people, like, put yourself on your own to-do list, give yourself, a reasonable amount of time that you could make some progress. And it doesn't have to be, finished. Sometimes just fine is such a great starting point. So, I would encourage you to do a little bit of homework, see what your hospital has in terms of data, because it's an important piece to sort of show validation that there is a problem as opposed to like just the perception that there's a problem. I would go to the literature and sort of see what that says, if there's a way for you to validate your tool, or find that some way that it's just more validated and reliable. And then I can help you think about your IRB, because doing some information and finding out your readmission, you don't need a IRB or anything for that, right? Because you're just trying to navigate information that's already well publicized within your institution. And then when you're ready to do that, we can put together an IRB and get that going.
Yes. And final thoughts on this. Our roundtables are all published online. We record them all. So if you want to go back to something, we can also, if you wouldn't mind putting up that QR code again, Susanna, for people. And this is a QR code that will, give you this tool that we kind of went through. I think it's not filled out, right? It's just a blank tool.
I don't know what Mo ended up doing.
Yeah, so we'll see. So if you want kind of this framework and, just like to put everything on there, go ahead and start using it. It's very fun. It's going to be great, whatever you do. And don't be afraid to take that first step. So we're getting a lot of comments and they're all, oh, Sue Gaines said it's blank. We will get it fixed and we will get a skeleton on there for you. We can also put this skeleton on our website too. So with that, if we don't have any more questions, it's 5:53. And if you don't have any more insights, I think what we will do, oh, one question. Do you have any recommended resources on the publishing process? Hope there's another roundtable. Very helpful.
In terms of like how I do this, or like how to publish itself. I mean, there is some literature about like how to publish as an APP, but it's not really well studied. So this I sort of made up of what I do for my process. So no is the answer, right? Because everybody works really differently. In terms of the resources, like how to physically do it and write the letter to the editor and how to write your highlights, you can usually find that from the journal author guidelines. If you go into whatever website you're looking for, you go to, Journal of Vascular Nursing and type in references for authors, and it'll tell you the format it wants and what font it wants and what references you want and things like that. So that's pretty journal specific in terms of that piece. So if that's what you meant, but if there's something specifically you want, I'd be happy to give you some insight into your own process if you're thinking about a specific problem.
Great. And one last plug for Journal of Vascular Nursing. Even if you just have a case study you want to write up, there's a clinical quarter that they're always looking for really interesting things, and about patients or, ways that you do your process at work. So, that's another thing, and we can help you with that too. All right. And with that, we will call it a wrap.
And I'll stay on for a couple minutes if you have specific questions about what you're doing and things like that.
Excellent. But we can probably stop the recording.